like, share, and subscribe here on Oncology Tube to get notifications when similar videos are available.
Hi everyone, thank you to Dr. Zell and Moaz for having me here today. Thanks for the invitation. My name is Shirin Attarian. I'm a medical oncologist. I recently moved here from New York, where I worked at Northwell Health Cancer Institute. I'm an incoming attending at UCI and will be starting there as a medical oncology for head and neck shortly. So let's dive in. I tried to include the most important studies from ASCO that are potentially practice-changing. So let's do this. I don't have any disclosures. First, to go over some statistics to put things into context. Head and neck cancer is the 7th most common cancer in the world, with 1.1 million new diagnoses reported annually. In the US, the incidence of oral and pharyngeal cancers is over 54,000 cases per year, resulting in over 11,000 yearly deaths. Male to female ratio is 2 to 4 to 1. Males are affected significantly more than females. There are clear socioeconomical patterns and regional variation in the disease. The socioeconomical pattern is not entirely explained by use of tobacco, and the regional variation of disease is explained by the relative prevalence of the risk factors that contribute to the disease. So this is the map of the world showing that there's clearly a higher incidence of disease in some parts. Southeast Asia and Asia Pacific regions have a particularly higher incidence of oral cancers. This is probably associated with chewing of the plant betel quid. Risk factors for the disease include tobacco and alcohol consumption, HPV infection for oropharyngeal cancer, and EBV infection for nasopharyngeal cancers. There's a steady increase in diagnosis of HPV-related cancers that's frequently oropharyngeal. I just want to touch on the important issue of HPV vaccination. The overall incidence of head and neck cancer is projected to continue to increase through year 2045, the overall. Under current HPV vaccination rates, it is expected that by year 2045, the incidence in younger population, 36 to 55 years of age, will decrease, but in the older population, the incidence will continue to increase. So basically, if everybody who is a candidate to get the vaccine got vaccinated now, the rates would still continue to increase through 2045. And the increase in incidence is largely driven by oropharyngeal cancer. And we have static survival rates. So I'm going to discuss 4 abstracts from ASCO 2023 today. Jupiter 2 trial, continuum, frail, immune, and depend. First, to go over Jupiter 2 trial, this study evaluated the emerging role of immunotherapy in recurrent metastatic NPC, nasopharyngeal cancer. So at ASCO 2023, the final overall survival analysis of Jupiter 2 was reported, which is a phase 3 randomized double-blind study of a PD-1 inhibitor called toripalimab, which is not available here in the US, versus placebo in combination with the standard of care gemcitabine and cisplatin as first-line treatment for recurrent or metastatic NPC. 289 patients were randomized, 146 to the toripalimab arm and 143 to the placebo arm. The study design is shown here. Patients were randomized to 6 cycles of standard of care gemcitabine and cisplatin plus toripalimab versus placebo. The eligibility criteria was primary metastatic or recurrent NPC. Patients were treatment naive and had a good performance status and had measurable disease. Patients were stratified based on their recurrent or versus primary disease, and sorry, something is popping up. versus ECOG performance status. The primary endpoint was progression-free survival, and the secondary endpoints were overall survival, among other. Just to remind you, at ASCO 2021, the progression-free survival analysis was reported that showed significant improvement with median progression-free survival of 11.7 versus 8 months. The one-year progression-free survival rate was 49% versus 28%, and an improvement in PFS was observed across all PD-L1 subgroups. So now, with a final overall survival analysis was presented that showed significant improvement. Overall survival is not reached in the toripalimab arm versus 33 months in the placebo arm. The 2-year survival rate and the 3-year survival rate were 78% versus 65% and 64% versus 49%. A consistent effect on overall survival favoring the toripalimab arm was observed in nearly all of the subgroups, and no new safety signals were identified. There are a couple other studies evaluating PD-1 inhibition in combination with gem and cis backbone. They're well underway. We have the progression-free survival data from all of the 3 studies, but the overall survival that we have currently is only from Jupiter. So in conclusion, for Jupiter 2, PD-1 inhibition with toripalimab plus gemcitabine and cisplatin demonstrated a statistically significant and clinically meaningful improvement in OS compared with chemotherapy alone as frontline therapy in patients with recurrent metastatic nasopharyngeal cancer. And this could potentially be practice-changing, and a PD-1 inhibition plus gem-cis is a reasonable standard of care option. Further studies are awaited. The next trial I'm going to discuss is the Continuum trial. This trial studied the emerging role of immunotherapy in locally advanced NPC. Patients with non-metastatic, high-risk, locally advanced NPC were randomized. 425 patients randomized 1-to-1, 210 in a PD-1 inhibitor sintilimab arm, and 215 in the standard arm. Patients were stratified based on stage and the center. Patients received 3 cycles of induction chemotherapy with gemcitabine cisplatin, followed by concurrent high-dose cisplatin for 2 cycles, and 70 grays of radiation in 33 fraction. Sintilimab was given every 3 weeks for 12 cycles in the study arm. The primary endpoint was event-free survival. The 3-year event-free survival rate was 86% in the sintilimab arm and 76% in the standard of care arm. Sintilimab had a positive impact on distant metastasis-free survival and local regional recurrence-free survival, but overall survival still remains similar due to the nature of disease. A longer-term follow-up is needed to detect overall survival difference. With regard to the safety profile, grade 3 and 4 side effects were seen in 74% versus 65% of patients in each arm. So in conclusion, for Continuum, addition of sintilimab to standard induction chemotherapy followed by concurrent chemo-RT resulted in significant improvement of event-free survival, a manageable safety profile, and comparable quality of life in high-risk, locally advanced nasopharyngeal carcinoma. These are also potentially practice-changing, though longer-term follow-up will be required to detect the difference in overall survival. Third trial that we're going to discuss today is a trial called Frail Immune. This trial studied new possible treatment with immunotherapy for recurrent metastatic head and neck SCC in patients who are ineligible to receive cisplatin. So basically, for patients who need chemotherapy, platinum 5-FU and pembrolizumab is the first-line treatment. This is associated with substantial toxicity, and it precludes a lot of patients who are cisplatin eligible or are fragile. So in this study, the efficacy and tolerance of a PD-L1 inhibitor durvalumab combined biweekly carboplatin and paclitaxel as first-line treatment in frail patients. Actually, the patients had a good ECOG performance status, but they were just not eligible to receive cisplatin. It's a single-arm phase 2 trial. 64 patients were enrolled, and the eligibility criteria was, as mentioned, recurrent metastatic disease, ECOG 0 to 1, cisplatin ineligible. Patients received 4 cycles of weekly carbotaxol and durvalumab. Each cycle was 4 weeks, and the durvalumab was continued after these 4 cycles for another 9 cycles. And patients were included regardless of PD-L1. In this trial, the median overall survival was 18 months, and the 12-month survival rate was 63%, and the 24 months overall survival rate was 45%. Other data from this trial, secondary endpoints, median progression-free survival of 7 months, objective response rate of 71 months, and median duration of response 5.9 months. With regards to tolerability, 84% of patients overall experienced grade 3 or more side effects, and 20% of this was attributed to durvalumab. 84% of patients required chemotherapy modification, and 56% required durvalumab modification. So in conclusion, for frail immune, durvalumab plus weekly carboplatin and paclitaxel may prove to be an effective first-line treatment option for recurrent metastatic cancer, head and neck cancer, in patients who are ineligible to receive cisplatin. The last trial that I'm going to discuss today is the DEPEND trial. This was a very interesting trial with an interesting design. This trial evaluated systemic induction chemoimmunotherapy to tailor a response-adaptive strategy in locally advanced HPV-negative head and neck SCC. The role of neoadjuvant immunotherapy in curative intent head and neck cancer remains poorly defined. Survival for this patient population is poor. The 5-year survival rate is about 50%. There's significant treatment-related toxicity in this group of patients with concurrent chemo-RT. So in this study, neoadjuvant nivolumab with chemotherapy was given to patients, and 36 patients were enrolled, so very small trial, but the patients were newly diagnosed, treatment naive, with measurable disease based on, with a good ECOG performance status and measurable disease based on RECIST. Initially, they received a neoadjuvant treatment regimen with 3 21-day cycles of neoadjuvant nivolumab, carboplatin, and paclitaxel. After the 3 cycles, a radiographic response assessment was done, and patients with more than 50% reduction by RECIST received response-adapted concurrent chemo-RT to 66 grays, and radiation to the elective nodal volumes were eliminated. Patients with less than 50% reduction in their tumor size after the 3 cycles of neoadjuvant chemotherapy and immunotherapy received the standard of care dose radiation with 70 to 75 grays, and they received radiation to the nodal volumes. Post-chemo-RT consolidation with nivolumab was given for 9 additional months. Primary endpoint was deep response rate, defined as the proportion of patients with more than 50% response per RECIST criteria after the neoadjuvant cycles of chemoimmunotherapy, And secondary endpoints were overall survival, progression-free survival, among other. This shows the patients that were the 36 patients that were enrolled. Patients were heavy smokers as expected, had locally advanced disease, so they had very advanced disease actually, and 55% had a CPS score equal or more than 1. This is the waterfall plot of this study. 54% of patients had a deep response rate as previously defined, and this group received the response-adapted radiation, the lower dose of radiation. The response-adapted radiation was associated with favorable survival and favorable local regional control. At 24 months, progression-free survival was 79% versus 46%, and overall survival was 86% versus 67%. And in this study, PD-L1 expression was predictive of deep response to nivolumab-based neoadjuvant treatment. In terms of safety and tolerability, as expected, patients who received a lower dose of radiation had much less side effects. So in conclusion, for DEPEND, nivolumab-based neoadjuvant chemoimmunotherapy led to deep responses, and response-adapted chemotherapy and radiation was associated with favorable survival rates and local regional control and better tolerability. Of course, further studies are needed to define the role of induction chemoimmunotherapy in this setting more. So the take-home messages are, for nasopharyngeal cancer in the metastatic setting, there's a clear role for adding a PD-1 inhibition to standard chemotherapy backbone with improvement in progression-free survival and now overall survival. For nasopharyngeal cancer in locally advanced setting, addition of PD-1 inhibition with sintilimab to standard induction chemotherapy, followed by concurrent chemotherapy and radiation, resulted in significant improvement of event-free survival. Overall survival data is not mature yet. In recurrent metastatic head and neck SCC, in patients who are cisplatin ineligible, PD-L1 inhibition with durvalumab with weekly carbotaxol showed an overall survival of 18 months and an overall response rate of 71%. Grade 3 or more toxicity was seen in more than 80% of patients. And last but not least, in HPV-negative, locally advanced head and neck SCC in the first line, systemic induction chemoimmunotherapy with nivolumab for 3 cycles, followed by response-adaptive concurrent chemo radiation with high-dose cisplatin was associated with favorable survival, favorable local regional control, and improved tolerability. So for future directions for head and neck cancer, I think it's really important and interesting to follow studies that are related to HPV cancer prevention, treatment de-intensifications in low-risk patients, biomarker-based therapies and response biomarkers, immunotherapy and immunotherapy sequencing, especially in locally advanced disease. There are a lot of novel agents that are being studied, and those are also very important and interesting. Personalized treatments, and of course, the severe impact of healthcare disparities, importance of diversity and equity in opportunity to take part in clinical trials. Thank you.
Like, share, and subscribe here on Oncology Tube to get notifications when similar videos are available.